Ladies and gentlemen, esteemed colleagues from around the world, welcome to the third day of the International AMR Innovation Mission UK 2021. I trust you're all safe and doing well. My name is Maarten van Dongen and I represent AMR Insights. AMR Insights started in 2016 and is a globally active network-based organization focusing on informing, educating and connecting professionals in the domain of antimicrobial resistance. Together with Innovate UK, Oxford Innovation and the National Institute for Health Research in the UK, we have initiated and now realized the first ever virtual innovation mission. The registration is now closed, and it is my pleasure to mention that we have exactly 400 registrations. About 200 from private companies, including from startups, SMEs and multinationals, and about 200 from academia, which is a perfect balance. The delegates are from over 60 countries. The aim of the AMR Innovation Mission UK 2021 is to add to the global curbing of antimicrobial resistance by boosting joint innovation and international collaboration. The scope of the mission covers the entire value chain, from early research up to and including marketing and sales. The first 2 days of the mission were focused on diagnostics on Monday, and yesterday, Tuesday, on antimicrobials. We had some great speakers and a lot of compliments for the program. The theme of today will be prevention and stewardship. And again, we have a great program with great speakers, and we really appreciate that you have taken time to register and to join this program this afternoon. I'll be your chairman today, and I would like to start with some practical points, including that speakers will be urged to finish on time. I will also inform them timely. The delegates can post questions online by the P2 match in the chat box, and we will answer these questions either during the session in the last few minutes, or we'll address these questions in a dedicated Q&A session from 2:45 to 3 o'clock in the afternoon, UK time. There will be a closing session from 3 o'clock to 3:15 UK time, where I, together with Dr. Peter Durkin of Innovate UK, will look back at these 3 days and make a sort of a wrap-up. Slides of all the sessions, including those of Monday and Tuesday, will obviously be made available. And also there will be recordings available of all the sessions from these 3 days. We will inform you on these separately after the mission by email. Please note that the Twitter handle for the mission is #AMR Mission UK. And we encourage you, obviously, to use this hashtag, this Twitter handle, to generate publicity for this mission. I would like to mention that people can continue to invite others for the partnering sessions. So far, we have over 160 partnering sessions, and there are also still many open invitations. We also urge you that if and when you have been invited by others to join a partnering session, then please to respond to these invitations. There are another 4 weeks to schedule these partnering sessions, so you will have ample time to get into touch with one of the about 400 participants of this mission. As chairman, it is now my pleasure to my honor to welcome the first speaker of today. And this is Mr. Santiago Gonzalez. And Santiago Gonzalez is the senior policy advisor to Senator Michael Bennet in Colorado, the United States. And this is not just a senator, because in September 2020, the Senators Michael Bennet from Colorado and Senator Doug Young introduced the famous pioneering antimicrobial subscriptions to end upsurging resistance, or in short, the Pasteur Act, to encourage innovative drug development targeting the most threatening infections, improve the appropriate use of antibiotics, and ensure domestic availability when needed. It's a great pleasure to have Santiago with us. I know that it's very early in the morning in Colorado, but nevertheless, he has made time available Santiago, please, over to you.
Yes, thank you, Martin, and good afternoon, everybody across the pond, and good morning to those of you who might be on my side over here. It is a great pleasure to be here, welcoming you all to day 3 of the virtual AMR mission. I hope that you all had some wonderful sessions on Monday and Tuesday, and I know that today, focusing on prevention and stewardship is going to be a really critical part as we have to work together to really buy time as we continue to figure out how to best address antimicrobial resistance. So I would just like to speak shortly this morning a little bit about the leadership that the United States is taking, and then I will highlight a little bit more about the PASTEUR Act and the work that Senator Michael Bennet from Colorado is doing alongside Senator Todd Young from Indiana. Many of you know, and many of your countries do this, but you put out action plans for combating antibiotic-resistant bacteria. And the United States, the Centers for Disease Control and Prevention, released their most recent action plan in October 2020. And what that really did was make sure that there was a plan with clear targets and goals to address antimicrobial resistance. And as an overview, the very top lines of the plan, which were developed to build on the plan that was released in 2015 under the Obama administration. And I will just highlight a few things. The plan will continue to prioritize infection prevention, which is what we're talking about today, and control to slow the spread of resistant infections and reduce the need for antibiotic use. The plan aims to ensure that patients receive the right antibiotic care, and the plan supports innovative approaches to developing and deploying diagnostic tests and treatment strategies. They would like to focus on a One Health approach so that we can recognize the relationships between the health of humans, animals, plants, and the environment, and integrate it throughout the plan with an expanded effort to understand antibiotic resistance in our environment. Finally, the plan focuses on collecting and using data to better understand where resistance is occurring, support the development of new diagnostic and treatment options, including new antimicrobials, and advance international coordination. And on that note, it's really great to be here because I know that the goal of this mission is to improve coordination so that we all, who will all be impacted by antimicrobial resistance and are being impacted now, can coordinate together on the best possible response. So the main difference in what we are trying to do in the United States is we are trying to coordinate amongst our own federal agencies to make sure that we are all reaching towards the same goals. And so all of our targets are coordinated targets across our federal government. And so with that, one of the main things that we are trying to do in the United States is lead on innovation and development, which we are very grateful for the work that many developers have done to address, to develop new antibiotics. But the fact of the matter is that there are many threats and critical threats that are occurring, and we do not have the tools that are even in development at this point to be able to address these needs. And so because of that reason, because of this broken marketplace, Senator Bennet and Senator Todd Young introduced the PASTEUR Act. And the aim of the PASTEUR Act is to develop novel and innovative antibiotics that are mainly aimed at treating resistant infections. We do not have enough of these in the pipeline right now, and we know that in 10 years, if we do not begin developing those now, in 10 years, we are going to see outcomes, not just in the United States, but across the world that are we're going to see far worse outcomes, and we're going to backstep on a lot of the innovation and a lot of the strides that global health has taken. The way that the Pasteur Act does this is it creates a subscription model. And the US government, if this were to become law, would invest about $11 billion into developing what we imagine to be anywhere from 5 to 7 really innovative antibiotics. We really think that with that innovation and with that investment, we will also create what I like to think of as terms and conditions to these subscription contracts. And those terms and conditions will include everything that we've talked about. It will make sure that those that are developing these products also are thinking about diagnostics, are thinking about stewardship, are thinking about all of the things necessary, and they're not just developing these things in a vacuum. And we are also thought about these terms and conditions include making sure that there's coordination and making sure that there is access to these new products across the world. And so we have developed this legislation, and as Martin said, it was introduced for the first time late in 2020. We are working on updating it with feedback from stakeholders across the world to make sure that we are targeting the research, the dollars that will be invested in this at the most innovative, the highest need drugs that need to be developed, and make sure that we also include provisions, which is what you all are talking about today, to make sure that our medical providers at every level are prepared to work on the prevention and the stewardship side of things as well. And so we are very excited and feel as though that this is really one of the largest investments that we will need to make, and the most critical investment that we need to make in order to address and really be prepared for the needs that we will have due to antimicrobial resistance. And so with that, I will wrap up, but I just want to say again that thank you to Innovate UK and to AMR Insights for having me. Thank you to the 400 registrants who are here and who are dedicated to coordinating efforts to fight antimicrobial resistance. And I am grateful to be here welcoming you all on the third day, and hope that you enjoy all the speakers and all of the folks here. And I am looking forward to hopefully connecting with some of you here in the future. And with that, I will turn it back over to Martin.
Jaco, thank you very much for your kind words, for your welcoming words. It's great to have you as well for you early in the morning during this innovation mission. The United States is obviously also involved in AMR and curbing AMR. AMR is also an issue in the United States. And I think that many countries look forward to collaborating with the United States to the curbing of AMR, not the least because you have so many initiatives like the Center for Disease Control, the Pew Charities, but also CARBEX and, for instance, the Gates Foundation. And these are all involved in curbing antimicrobial resistance. Thank you very much once again. And I hope that you can stay for some longer time during this mission, during this afternoon program. Now it's my pleasure to introduce to you the next speaker, and that is Professor Carl McLennan. And Professor Carl McLennan is involved in what I just mentioned, the Bill and Melinda Gates Foundation. He is responsible for bacterial vaccines, global health, enteric and diarrheal diseases. He is also a senior clinical fellow and general investigator at the General Institute of the University of Oxford. And he is a professor of vaccine immunology and director of Bacterial Vaccines Network at the University of Birmingham. In view of his broad responsibilities, it's great that we can welcome him today at this third day of the AMR Innovation Mission. I know that the focus of the research of Professor McLennan is especially to understand the immunological basis of protection against invasive bacterial disease with a view to prevention and treatment, focusing on communities and resource-limited settings, and patients with impaired immunity. Well, today's theme is what I said before, is prevention and stewardship. So it is, well, my pleasure and honor to give the floor to Carl McLennan. Carl, over to you.
Many thanks, Martin, and huge thanks to AMR Innovations for the opportunity to speak today. And I will do so from various different perspectives, but the title said this is going to focus now on vaccination in relation to curbing AMR from both the perspective of this country, the UK, and from a global perspective. Next slide, please. So if we just take a snapshot to start with of antimicrobials compared to vaccines and their longevity in terms of effectiveness going forward, I think we can see from this chart here that the vaccines tend to be the winners. So unfortunately, all along, antibiotics have their period of effectiveness and then resistance develops, and that seems to be almost inevitable. That has occurred for every antibiotic, every antimalarial so far. In contrast, if you look at the lines at the bottom, vaccines beneath antimalarials and antibiotics, you see those lines continuing through, and some vaccines that were developed in the early part of the last century are still being used and doing their job today, such as diphtheria and tetanus vaccines. And the one disease we did manage to eradicate, smallpox, that was very much driven through smallpox vaccination. So if we can increase our scope with relation to vaccines, we could have a good chance of overcoming the problem of antimicrobial resistance. Next slide, please. And as those of you who've been on the 3 days of this mission will be aware, tackling antimicrobial resistance relies on a number of different approaches, as was discussed earlier by Mr. Gonzalez. Of course, we need new antibiotics, we need diagnostics and good stewardship of antibiotics. We need to see if there are alternative therapeutics as well. But in terms of vaccination, we're looking upstream at this point. We're looking at preventing infection along with other interventions like WASH. And we really think in the field of vaccinology that prevention is better than cure here. And so vaccines, although they take time to develop, although they are expensive to develop, they do, in terms of long-term options and in terms of long-term impact, they really are a major factor to consider in terms of dealing with antimicrobial resistance. Next slide, please. And in terms of how, if we just take an overview to start with how vaccines can tackle AMR, there are three main ways that they can do this. They can do it directly by preventing infection, including with that carriage and transmission of microbes which are drug resistant. They can reduce the occurrence of the symptoms of these diseases and thereby decrease antibiotic use, which is the driver of antimicrobial resistance. And they can also prevent secondary infections with drug-resistant organisms. And here we're thinking of vaccines against not necessarily bacterial pathogens, but say vaccines against influenza, where that can help prevent secondary infection with Staph aureus causing pneumonia. So next slide, please. And just here we see the vaccines versus the AMR pathogens themselves can impact through all of these three different areas. And all of these three areas, those against non-AMR pathogens, such as vaccines against influenza and other viruses, can impact in terms of reducing symptoms and those secondary bacterial infections. And that really is not to be underestimated. Now, I'll have a slide to demonstrate that shortly. Next slide, please. And in terms of the immunization, we can think of the vaccines against antimicrobial resistance pathogens acting in two different ways, having both the primary direct effect in terms of those antibiotic resistant infections by eliminating them, and then that secondary effect by reducing antibiotic use. And so you've got these two different main ways that are driving the effect that vaccines can have against AMR. Next slide. And the UK has had a lead in this in many different ways. This is just one that I'd like to highlight that I'm sure many of you are aware of, which was the O'Neill report published in 2016 and commissioned by the UK government and supported by other organisations as well. And one part of this report into antimicrobial resistance highlighted the role that vaccines can play, but it also tried to predict going forward what the toll could be from AMR in the future. And it's very difficult to do these predictions. It's difficult even to come up with a figure now. This figure for currently estimated 700,000 deaths as being the reason for, as being attributable to antimicrobial resistance, but it predicted 10 million in the year 2050 if we don't take steps to deal with antimicrobial resistance. And as part of this section of different papers that the report included, one was directly on the role of vaccines. Next slide, please. Thinking more internationally now, the WHO have been moving in this area for some time now. This is just to highlight the most recent action framework that was published this year, 2021. And this is for the leveraging of vaccines to prevent antimicrobial resistance and really focusing on three different areas. Firstly, those vaccines which are already licensed, but maximizing their impact, increasing their usage. Secondly, the development of new vaccines that can then contribute to the control of antimicrobial resistance. And finally, thirdly, expanding our knowledge of AMR and sharing that with others, and particularly the role of vaccines in impact on antimicrobial resistance. Next slide. Now, you'll know from the introduction that Martin gave that I work for the Bill and Melinda Gates Foundation, and our perspective on antimicrobial resistance aligns very well with that of the WHO. Our priority populations that we're interested in serving are those in low and middle income countries. And we're really interested in antimicrobial resistance in relation to how that can jeopardize our targets that we seek to achieve in terms of health aims amongst these populations. And so we're interested in understanding the impact of AMR, but also preventing and reducing the burden of that antimicrobial resistance. So we focus support, we give grants to help develop tools to reduce mortality and disease burden in these populations. And a large part of that has been through vaccines. We're also very keen on making sure that there's appropriate use of antibiotics so that those aren't used more generally than that they're needed. But vaccines is very much core at the work that we do at the Gates Foundation. Next slide, please. And so if I summarize what we're doing, we work for prevention, infection control, and appropriate use of antibiotics. But in terms of the prevention side of things, those of our teams in global health, and the Gates Foundation broadly divides into global health and global development. Global health is very much vaccine orientated. So my team, the enterocondral diseases team, are working on vaccines against typhoid, Shigella, cholera, and rotavirus. The pneumonia team is working on vaccines for RSV, GBS, and pneumococcus. And then we have teams working on vaccines for HIV, TB, and malaria. And we see this as a major way that we can drive down infections and deal with antimicrobial resistance. But if we think about our colleagues in the global delivery part of the foundation, this is where we're really looking at maximizing the delivery of those vaccines that we've got and vaccines as they come through to licensure and WHO pre-qualification. Next slide, please. So what evidence do we have already? And there are examples already of how vaccines are having impact against antimicrobial resistance. And perhaps the best examples are from the world of pneumococcal vaccines. And these are data from South Africa, where pneumococcal conjugate vaccines have been implemented, both PCV10 and PCV13. And you can see with time from 2005 through to 2012 that there's been large reductions in the incidence of disease of pneumonia caused by strains of pneumococcus that are resistant to these different antibiotics in the figure, such that we've got over 80% reduction in cases of pneumococcal pneumonia resistant to penicillin-based antibiotics, and also against triaxone. So this has been great to see this effect, and it's also led to a reduction in use of antibiotics as well. Next slide, please. And then looking at the future, sort of in my area of enteric and viral diseases, where typhoid vaccines, typhoid conjugate vaccines have been pre-qualified in the last couple of years, and we're now looking at rollout with Gavi. Can these vaccines change what's happening in terms of antibiotic prescribing behavior? And this is really important, because if we can reduce the burden of disease, then we're going to reduce the need for antibiotics, and we're going to reduce that driver of antimicrobial resistance. So if we look at fever in typhoid endemic areas of the world, say South Asia, Southeast Asia, most of febrile cases are caused by viral infections, but because typhoid is endemic in these countries, often patients will be given empiric antibiotic treatment. And what you can see here from the figure is that in these different countries, in studies that have taken place of suspected typhoid fever cases and those who actually have typhoid fever, for every one patient who actually has typhoid fever, you've got 3 to 25-fold as many patients being treated with antibiotics. So if we can drive down the disease that's occurring through our vaccines, and that's not going to be just typhoid, but vaccines against typhoid, but also against some of these other diseases which are viral, caused by viruses, then we're going to reduce that antibiotic usage. And you can make similar arguments for other pathogens such as group A streptococcus. Next slide, please. I talked about vaccines against viruses having impacts. Well, this is a neat example from Canada, where in Ontario in 2000, free universal seasonal flu vaccine was introduced. And what you can see from the figure on the right here is essentially each of the different Canadian states represented by a circle, and it can show on the y-axis the pre and post 2000 relative rates of prescription. So they're all around 1 for most states. Ontario, the rates of prescription went right down, and that corresponded with a rise in vaccination rates. So obviously, this is showing the association, doesn't necessarily show the causality, but these are good data to support the value of vaccination in driving down AMR, driving down infections and prescriptions, and not necessarily being with vaccines against bacteria themselves. Next slide, please. So returning to the WHO, I'm sure you'll be aware of the AMR priority pathogens that the WHO listed of some years ago, as well as those where vaccines are available: pneumococcus, Haemophilus influenzae B, and typhoid that we've just been talking about. There's a list of 15 other pathogens here. And from my perspective as an enterics person, we've got Shigella here, we've got non-typhoidal Salmonella, Salmonella paratyphi, which are the other forms of invasive Salmonella disease alongside typhoid, and also Campylobacter and ETEC amongst the E. coli. Next slide, please. Now, what Wellcome did, obviously based in the UK a few years ago, was really neat. Their vaccines strategy actually went and followed these AMR pathogens and commissioned a report by the Boston Consulting Group to look at these vaccines in relation to tackling drug-resistant infections and looking at that in terms of R&D opportunities. This was a document produced for funders, for biotech companies, and they scored the different pathogens in various different ways to try and give a handle for those who are trying to address the problem of antimicrobial resistance with vaccine development. Next slide, please. And the scorecard for these different pathogens had 3 main areas: health impact. So what was the impact of these diseases in terms of mortality and morbidity? What was the urgency of the antimicrobial resistance threat? And how much antibiotic use could be attributed to those particular pathogens and diseases. Then what was the probability of R&D success in relation to pipeline robustness of vaccines that were in development already, the biology of the pathogen, and the ease of preclinical and clinical research and development. And then finally, the probability of uptake should these vaccines be developed, be licensed, and be pre-qualified, because someone has to use them, someone has to pay for them. Next slide, please. And out of that report that was commissioned by Wellcome, I think this is probably one of the most useful figures. And what this figure does, it plots on the x-axis the probability of R&D success, so the one measure for those different pathogens. And then on the y-axis, the health impact, that measure of mortality, morbidity, and AMR threats. And you can see the 15 pathogens here, as well as the 3 that already have the vaccine, so pneumococcus, typhoid, and influenza. So over to the right, these are licensed vaccines. These are designated by dark blue, which, as you can see at the bottom, is where increased uptake needs to be driven. So that's a delivery aspect that needs to be taken care of. And the size of these different bubbles correspond to the calculated incidence for the different pathogens. Then as you move left across the figure, you can actually see that those enteric pathogens I've mentioned already, Shigella, non-typhoidal Salmonella, E. coli, so enteric, so enterotoxigenic E. coli, and Salmonella paratyphi is the small dot there. They're the next ones to the left. So these are where we've got pipelines in various different stages, and the priority conclusion from the report was to bring these vaccines through to market. Then moving a little further to the left, where the probability of R&D success is a little bit less, and you haven't got those vaccines in the pipeline yet in clinical development, advanced to early R&D. And I'd like to just emphasize here, right in the middle, Neisseria gonorrhea, so gonococcus, the causative agent of gonorrhea. And then towards the left, pathogens represented by gray circles, where the emphasis is to collect more data to explore alternative treatments. Next slide, please. And this slide really just does that categorization of those different pathogens according to the colors, where the emphasis is for the different pathogens to either increase uptake, to bring to market, advance early R&D, or to collect more data. Next slide, please. So one of the things at the Gates Foundation that I'm responsible for is the Shigella vaccine portfolio. So I thought I'd just walk through this as an example and talk a little about the Shigella pipeline that we have at the moment. And here, this is an example of a scorecard. Essentially, the scores go from 0 to 2. 2 is the maximum. So 2 means this is more of a priority or has a greater chance of success. So morbidity, very high with Shigella. Shigella actually is the largest cause of diarrheal deaths in children over 2 years of age, and the largest cause of diarrheal deaths in general, next to rotavirus, which has vaccines now. You can see probability of R&D success in green as well, these 1.5 figures. And then some yellow ones as well. What would the impact be on antibiotic use? What's the urgency of the threat? But altogether, these numbers put Shigella as one of the priority pathogens higher up that priority list compared to some of the others. Next slide, please. And this is now just from the Gates perspective of what we see as the need for a Shigella vaccine. The case for this was one of our annual review slides from a couple of years ago. And what we discovered looking at the burden of disease, where we moved from just looking at culture of the Shigella bacteria from stool and switched to using molecular methods, we were then able to attribute the etiology to far more diarrhegenic diseases. And as a result of that, Shigella actually took a much greater share than we'd originally seen when we were just relying on culture. So Shigella burden, it turned out, was rather higher than we anticipated just a few years ago. It also has impact on growth faltering, and that's thought to be due to its inflammatory nature. And finally, and importantly for the purposes of this talk, the antimicrobial resistance is growing. And the figures that we had when the slide was prepared were actually very limited. So again, this emphasizes the need for collecting data on antimicrobial resistance. Next slide, please. And this demonstrates the Shigella vaccine pipeline and why we have a robust pipeline. And the pipeline is predicated on the success of a vaccine, which was demonstrated in a phase 3 efficacy study now 24 years ago in Israel, where a first conjugate vaccine of O antigen of Shigella sonnei conjugated to a carrier protein had 74% efficacy. Unfortunately, this was never taken to further development, and I think this emphasizes over the last 25 years the dearth of investment during the early stages of that in vaccines that don't have the general commercial incentive, but are really really important in terms of global health and low and middle income countries. And that's something that I see being redressed by the Gates Foundation, by Wellcome, and hopefully by governments such as the UK government in terms of their spending through UKRI and through Department of Health and Social Care. So the other vaccines that are in this pipeline, which are represented by the different colours, and we can see the funding there with Wellcome represented there, as well as the Gates Foundation, DFID as it was, European Community. We can see we've got quite a robust pipeline. And we actually have vaccines now in the target population of children, infants of 9 months of age in low and middle income countries. Next slide. And just as the COVID pandemic has pushed new technologies for viral vaccines for mRNA and adenoviral vectored vaccines, it's been exciting to see in the Shigella field new technologies being pushed forward for these different vaccine candidates that are going forward. We have technologies where the Shigella vaccine is actually being created within genetically manipulated E. coli bacteria, so that the conjugate vaccine can then actually be purified from E. coli like a recombinant protein. We have a vaccine that's being developed by synthetic chemistry, where the building blocks of the O antigen are being put together by chemists and then conjugated to a carrier protein. And then at GSK, there's a technology that is increasingly being looked at, where gram-negative bacteria such as Shigella are being manipulated so they actually increase the release of vesicles from their surface, and these can be harvested as vaccines. Next slide, please. And then looking at the global and the UK perspective, I just want to turn our attention for a couple of slides to gonorrhea. This is a global threat. When you think of 87 million new cases per year, that number is over 1% of the global population. So it won't surprise you. The prevalence figures here are around 1%, but particularly a problem in women in Africa, where they approach almost 2%. And infections are associated with adverse reproductive health outcomes and increased risk of HIV infection. In the UK, there's a separate market here that could very much benefit from a gonococcal vaccine, and that's been shown by the increasing cases over the last decade. And this is groups such as men who have sex with men and other high-risk groups. The problem with gonorrhea is that it doesn't tend to cause death, so it hadn't been high on the global health perspective and in the perspective of organizations like WHO for that long. That perspective has changed with antimicrobial resistance. Next slide. So what we can now see is there's no reliable monotherapy to treat gonorrhea, and I'm so sure those of you who followed the news and seen what's happened in the last few years with gonorrhea is the threat of untreatable gonorrhea. And you can see from these maps of the world that antimicrobial resistance is rife throughout the world. And so this really has put gonococcus right up the table in terms of need for a vaccine. Next slide, please. However, there isn't, unlike Shigella, a robust pipeline at the moment. In fact, there hasn't been a clinical trial of a gonococcal vaccine for over 30 years. But what gives us some hope was actually data that came from use of a vaccine against meningococcus. So this is disease caused by Neisseria meningitidis, the same genus as Neisseria gonorrhoeae. And what turned out was that a vaccine with vesicles that was used in New Zealand to deal with an outbreak of group B meningococcus led in a retrospective case control study to a finding of 31% efficacy against gonorrhea. So one of the things that we're pursuing at the Jenner Institute at the moment is a gonococcal vaccine based on outer membrane vesicles. And this is with the hypothesis that if a vaccine against directed against meningococcus can have efficacy against gonorrhea, then surely one with the same approach that's predicated on gonococcus should have greater efficacy against gonorrhea. Next slide. So in the last few minutes, I just want to mention one other initiative in the UK, which I've been very much involved with, and with I'd like to thank the UKRI and the Global Challenges Research Fund for. And this is where our overseas development assistance is so important in the UK, and we really hope that that gets reinstated by the government. This is the establishment of the back-to-back bacterial vaccinology network back in 2017 as part of a set of 5 different vaccine networks were set up at the time. And the reason for this was that really there was no vaccine network again for bacteria and for vaccinologists focusing on bacteria. And the threat of antimicrobial resistance was a major driver and justification for setting this network up. We've got expertise in the UK on this, but we need to link with people globally as well. And this really at the time contrasted with the focus on viral and outbreak pathogens, one that's really only been magnified by the occurrence of the COVID pandemic. Next slide, please. So what is our mission in Back-to-Back? Well, really, we're looking to be a voice for bacterial vaccinology and to help accelerate vaccines against bacterial pathogens of global health significance along the bacterial vaccine pipeline. We look to bring together academia and industry, low middle income country researchers with those in high income countries and policymakers as well, such as those in the WHO, and build a sustainable network for vaccine development so that we can bring together different players in this field who have different expertise. Next slide, please. Since 2017, our membership has grown to over 1,100, spread across 74 different countries. And although we're centered in the UK, 48% of our membership are from low and middle income countries. We've got a growing representation from industry, and we see this as all important in linking academia with industry. So 13% are industry members, and we've got increasing contacts with members and industry in developing country through the Developing Country Vaccine Manufacturers Network, who ultimately, those member companies are likely to be producing the global health vaccines we need. Next slide. One of the things that we're proudest of in the network is the projects that we've funded, and these are with relatively low seed funding, around £50,000 a time. Out of 40 awarded projects, 29 have been completed. And from the £2 million we've invested in those projects, if we just look at the bottom line down there, the substantive funding that's been leveraged in follow-on awards is over £12 million. So we're really happy about that. We're really grateful for additional funding from the DHSC and from GAMREF to support this initiative. Next slide, please. And finally, we see a role in advocacy as well, both in the UK and globally, for the importance of bacterial vaccines and for bacterial vaccines against antimicrobial resistance. Next slide, please. And with that, I'll finish with just this summary slide. So in summary, vaccines play an important role, have a hugely important role to play in dealing with AMR in 3 different ways: reducing drug-resistant infections, reducing antibiotic use, and reducing secondary infections. And we need action now, and we are pushing this action both in the UK and globally through the different organisations I've mentioned to expand the use of existing vaccines, to develop new vaccines that are needed, and to collect more data, because quantifying the impact of vaccines and quantifying the actual burden from antimicrobial resistance is challenging and requires a lot of effort. And with that, I'll finish. Thank you very much.
Thank you very much, Carl, for your interesting, clear, and very convincing presentation on the potential of vaccines to curb antimicrobial resistance. And it is clear from your presentation that, well, there is an enormous potential, but also still a lot needs to be done to further make use of this potential. And we, all of us, can only hope that this potential will be further used and exploited in the future. So thank you very much. If there are any questions in amongst the audience, I mean, it's possible to ask your questions in the chat box, and we will address these questions. We have still some time now But we can also do this later in the afternoon from 2:45, 3 o'clock UK time. And Cole, there's no questions yet, but I wanted to raise a question, and which is something which is partly related to your presentation. You mentioned the Jim O'Neill report, and also the number of expected number of deaths in 2050, being estimated at about 10 million per year. And as you know, I'm involved in AMR on a daily basis, and I'm dealing with two different types of people. People saying, including scientists saying, 10 million is an enormous overestimation, but also scientists saying, 10 million is an underestimation because the problem is much more worse than we can ever think of. Can you comment on this discrepancy?
Yes, certainly. I mean, I think obviously it's an estimate, and estimates, as we know from modelling, even in the pandemic, can vary widely and can vary in terms of their prediction in relation to what's actually delivered in the meantime. One thing that I think is important to do at the moment is to try and quantify the level that we have at the moment that is caused by antimicrobial resistance. And the IHME, the Institute for Health Metrics and Evaluation, who deliver the Global Burden of Disease report, have been working hard on this over the last 5 years, and actually are in the process of finalising a report on the current level, which I think is going to be really helpful, because that starts to give more evidence than a sort of broader estimation. And I think if we can look at what that is and we can track where that's going, that will help us know where we are. It's very difficult to predict out to 2050, but I think the important thing is that people and governments and funders are aware of this silent pandemic of antimicrobial resistance and don't just ignore it because it's not in your face like the COVID pandemic.
No. Thank you very much. I couldn't agree more. And again, thank you very much for your presentation. I hope you can stay with us for the rest of the afternoon. It is now my pleasure to welcome our next speaker, and not only my pleasure, but also my honor to introduce Professor Jeanette Hemingway. Professor Hemingway has been the director of the Liverpool School of Tropical Medicine for many years. She is now a professor of vector biology at the Liverpool School of Tropical Medicine. She has been a PI on recent projects, including the Bill and Melinda Gates Foundation-funded Innovative Vector Control Consortium, the UKRI-funded ICON Consortium, and she will tell more about it this afternoon, and the ARDF-funded Formulations Program, and the BMGF-funded Physical Leishmaniasis Elimination Program. A few words about the ICON Consortium. This is led by LSTM, the Liverpool School of Tropical Medicine, and it has partners including the Liverpool University Hospitals, NIH Foundation Trust, Evotech and Infex Therapeutics at Elderly Park, Chess Hire, Unilever UK, and University of Liverpool. Professor Jeanette Hemingway, it is an honor to welcome you here, and the floor is yours.
Thank you very much, Martin, and thanks for a great talk as well, Cal. We need to reconnect, given you have various hats on now, and I've got different hats on. So I think there's potentially a lot of benefit in linking up again there.
I'd like that a lot. Thanks, Janet. Good to see you.
So what I wanted to talk to you about was really a new consortium that I established late last year. We had already put in the bid to UKRI for this pre-COVID, so it wasn't stimulated by COVID, but clearly has been able to pivot and do a fair amount of work around the COVID area. But a lot of the activities that we've been working on are relevant to AMR and to the meeting today. So I wanted to concentrate on that area of the new consortium today. Next slide, please. So it's anchored in the north of England, or in the northwest of England, because it's been funded by the UKRI Strength in Places Fund, and involves core partners from the Liverpool City region and Cheshire and Warrington. But we then have an outer ring of partners who are philanthropic donors, industry, other academic partners, and other NGOs, that amount to around 120 different organisations at the moment that are already interfacing with this consortium. It was funded in September of last year with an £18.6 million investment from UKRI, and it's already leveraged up to 173 million from income coming in from various sort of streams across the platforms that we've got. And it's growing sort of rapidly. So literally there is a press release going out today that tells people that the Nanotherapeutics Hub based at the University of Liverpool and linked to Strathclyde and Glasgow have also joined this consortium. Next slide, please. So what are we doing? Well, we're enabling through partnership SMEs and large-scale industry to work with research institutions to actually co-develop and de-risk new infectious disease formulations. And by infectious disease formulations, I mean everything from vaccines, drugs, antibiotics, diagnostics, through to public health insecticides, because we realise that a lot of these suffer from the same problems along that pathway from first initial sort of identification of a possible active through to getting something into the market. And I think Cal's example of vaccines that had even got to the phase 3 trial and then stopped suggests that those problems are endemic, if you like, across this space, and something that we need collectively to try and tackle. So we're also not just stopping at getting the products to the point that we've demonstrated efficacy, but we're also looking at how we actually help industry to validate and position those effectively in the markets. And we're doing this through open access platforms that we believe are going to be cheaper, quicker and smarter than the way at the moment people are trying to develop these new therapeutics. Next slide, please. So specifically around antimicrobial resistance, we have a number of platforms. The very early stage of this is looking at how we can develop new antibiotics. And there we have a massive natural product library, which is already enhanced for activity against AMR pathogens that we're working with industry to look at high throughput screening. And I'll say a little bit more about that in a minute. We've established a Hits to Lead program working with local SMEs to actually take molecules either from an academic base or from other SMEs that are stuck at even getting these things through to early clinical trials and try and winnow out those that are sensible to take forward and help them get to the point of at least first clinical efficacy trials. We're providing new humanized organoids to look at high throughput screening models for assessing and refining the toxicology profiles for promising new drug leads against AMR pathogens. And again, I'll say a little bit more about that. And we're providing new rabbit and mouse models for screening promising drugs and looking at the pharmacokinetics and pharmacodynamics of those actives. We're then providing a novel human challenge platform, which is cheaper, but also rapid and safe to look at a first into man step, which is specific for some of the AMR pathogens. And then finally, we're defining the way that these pathogens are distributed through populations in 3 different economic settings, Malawi, Uganda, and the UK, to help industry work out where product placement could give the greatest impact. Next slide, please. So if I look a little bit more detail at some of these slides, those that are highlighted here in the dark green are the ones that are really relevant to AMR. And I'll start and go through these in a bit more detail. The one that I'm not going to talk about in a lot more detail is the in vivo models for the animal models. And that is just a rabbit and a human model specifically for Acinetobacter infections and nosocomial pneumonia infections that we should have available fairly shortly. But I'm not going to say any more about that. But all of the other platforms I will say a little bit more about as we go forward. So next slide, please. So to start with a natural products library screening platform, we've teamed up here with AstraZeneca, who are making their high throughput screening facility at Alderley Park available for this. And even when AstraZeneca move away from Alderley Park and decamp completely into Cambridge, they will leave that screening facility in Alderley Park, and it will spin out as an SME that will undertake this activity with us going forward. Onto that platform, we're putting a huge natural product library, which has been the output of a very large swab and send citizen science antibiotic discovery project that's been running for about the last 6 or 7 years, where we now have a vast range of isolates that we are now fractionating in a way that will allow us to screen the library using the standard industrial library screens. We're making that library modular so that industry, if it has a particular interest, could actually screen against the soil isolates or skin isolates, home isolates, animal isolates, for example, and so on, or they could screen against the entire library. And then we can identify the compounds that result from that screen, working with our industrial counterparts via mass spec, and clearly either take that on with them, or the industrial partner can take that on their own. Next slide, please. Moving on to the next of our platforms, that's a human organoid screening and drug optimization platform. Again, people have tended to look at this early stage screening using standard microtiter plate screens, which are good, effective, high throughput, but they didn't really mimic what happens often in a human organ. And so we've been looking at how we can improve the way that we can set up a human organoid 3D cell culture system and put that into a high throughput screening facility. So this is sitting in our BSL-3 pathogen facility, which allows us to handle a range of different pathogens. And we are developing a repertoire of human organoids to establish PK/PD efficacy in this physiologically relevant system. Next slide, please. So to give you an example of this, there's a publication just accepted, which will be out in the press very soon, that we've developed with NuCell as a model for lung, where we have derived basal-like cells of high purity from a mixed population of lung progenitors that we can set up in a functional system that has the various sort of layers that you see here, including a beating cilia layer at the top of that system there. And we can put that into the high throughput screen to test compounds where we believe there should be activity in a lung organoid, for example. We have similar skin organoids already up and running, and we're working on a number of other organoids that should follow quite rapidly behind this. Next slide, please. Alongside that, we can do the standard infection sort of models, looking at these things in microtiter plates. So it's not that we're not doing that. We can add this on to the screening facility that we already have so that we can look at standard toxicology and drug activity with a range of different concentrations. Next slide, please. Once you've gone through the human organoid, then clearly the next stage in this process is to get into a first into man type system. And we've been working for quite some time on human challenge models that present an opportunity to significantly de-risk transition into man studies, which are hugely costly and require high participant numbers. The human challenge requires far fewer volunteers at the early stage of doing this work. And we already have the system up and running for pneumococcus with successful screening going on with large industrial counterparts. But we're further developing the model for pneumonia, RSV, influenza, and multi-drug resistant TB, and have an extended clinical facility to be able to do that. Next slide, please. So as part of the Strength in Places program, we moved our program for the Human Challenge out of a relatively small 3-bed sort of unit that was sitting in the research facility and expanded that into an 18-bed facility that you see here. That was pivoted almost immediately to deal with the COVID pandemic. And we actually operated as one of the Oxford AstraZeneca vaccine trial sites for the SARS-CoV-2 vaccine, and were one of the most successful trial sites there, with 1,000 participants vaccinated, the most rapid scale-up of getting volunteers in, and we've now got a number of ongoing studies from there. So the plan is to expand this facility even further, linked up with our NHS Trust partners to roughly double the size of the facility that we've got already immediately on site adjacent to the hospital trust. Next slide, please. But this isn't all about drugs or vaccines, although as you can see, we can take many drugs and vaccines through those particular pipelines. But we're also interested in looking at the diagnostics side of this equation as well. And we have 2 arms to our diagnostics platform, one of which is actually using new sensor technology and electromagnetic wave technology for non-invasive detection of infections, particularly those that you can detect in peripheral blood without needing to take a sample of peripheral blood. But we're also working on the more classic diagnostics in terms of molecular diagnostics, lateral flow diagnostics that everybody has heard a huge amount about over the last few months. We're a site, a validation site for FIND, the product development partnership largely funded by the Bill and Melinda Gates Foundation for diagnostics. And we're also a WHO validation center for diagnostics largely going into low and middle income countries. And we can also take products through MHRA registration in the UK. So the idea there is to work in multiple channels. One, to work with companies who are in the early stages of developing new diagnostics and try and improve the rate at which they get their diagnostic through to market and do problem solving along the way for the products that they've got at different translational stages in that pathway. The second is to actually take their developed diagnostic and do a third-party validation of their technology where they can then use the data to go to the regulatory and normative agencies to get their new diagnostics approved. Next slide, please. I should say we have been doing that for a range of AMR programs, but we've also pivoted that particular platform to working with SARS-CoV-2 as well over the last 6 to 9 months. So many of the platforms and expertise that we've got here are agnostic in terms of the actual organism that we're dealing with. And we have the ability to flip these platforms to handle changes in the demand that is coming through from the industrial counterparts that we're working with. We're also aware that a lot of small companies in particular find it very hard to access these facilities and ask the right questions up front to actually get their products moving. Many SMEs are very small teams who struggle to actually get things out through to the market. And so knowing that, we then teamed up with the European Regional Fund. And although it's the last phase of that funding coming through into the UK, having exited the European Union, we currently have another £6.6 million to give free access to many of our technologies in 3 particular areas to regional SMEs to help them progress their products through different TRL stages to try and get those to market. And that allows us to work with those companies on the early stages and hopefully get them to the point where their products are much closer to the point where they can get follow-on funding to take those through into the marketplace and make sure that we don't get too many failures because of lack of funding and lack of know-how coming through that large SME cohort that we've got working within this area. Alongside the ERDF offering, we're also linked up with the Medicines Discovery Catapult that sits in Alderley Park. They have a range of different equipment, and up till now, they had been working outside the infectious diseases space, but they have recently got funding from the local enterprise partnership in Cheshire and Warrington, linked up with ICON to take them into the infectious diseases space as well. So they will have BL3 facilities, and they will have an offering for companies who are interested in taking things into the infectious diseases space through that Medicines Discovery Catapult very shortly, and will formally link up with ICON. And again, you'll hear a press release coming out on that before very much longer. Next slide, please. So just to finish off, really we are open for business. We are very keen to hear from people who would like to link up with us, who would like to see how best we can help them innovate. We're keen not to reinvent the wheel. So if people already have things going, then we would like to team up with them. But we are very much about trying to get the ecology of the R&D landscape for infectious diseases, particularly in the northwest of England, but I think in the UK more broadly, up and running so that we can do things far more efficiently together than any of the partners to date have been able to do independently. And there I will finish and say thank you very much for your attention and leave time for a few questions if anybody has any.
Jeanette, thank you very much for your very clear but also very encouraging presentation on ICON. I'm very much impressed by the initiative, and I think I'm impressed for several reasons. I'm impressed by the 9 different platforms. I'm impressed by the fact that you actively also are looking for, well, collaboration with academic institutes, research institutes, but also with private companies, startups, SMEs and multinationals. And especially the startups and SMEs, because these organizations may desperately look for the solutions you're providing. I'm also very much impressed because of the multi-purpose setup of ICON. I mean, setup for AMR, but also applicable, what you just mentioned for COVID-19, and which makes it even more attractive. And this was one of the first slides. Well, the objectives include building partnerships, co-developments, and de-risking, but also progress ideas to the market. And from that perspective, also your presentation and also the ICON initiative perfectly fits into this AMR innovation mission to the UK, because it's all about partnerships and joint innovation. So very, very impressive. And If people have questions, then they can put these questions in the chat box, and then we will just forward them to Jeanette. As a start, I have a question myself. I mean, this is clearly a UK initiative, located in the UK and also based in the UK. How do you look at, further internationalization of this initiative? AMR is clearly a global threat, it's a global problem. Can you elaborate on that?
So I think there are two things. One is that although we're UK based, we've got companies from all over the world who are already working with us. And so we won't just work with UK business. We will work with any companies or SMEs that want to take things through. The funding mechanisms may differ, and we would need to look on a case-by-case basis as to how we do that, because what we don't have is a pot of money to give out grants. But we're looking at different routes we can facilitate that. The other thing that we're trying to do is make sure as we develop these technologies that we talk with the regulatory agencies and others to try and make sure that if we do have a better way of moving things through more quickly to market, that we can get that accepted as the industry standard, accepted as the regulatory standard, so that not only we operate this way, but others start to operate that way as well. And we've done that, as an example, from the product development partnership I set up back in 2005 with public health insecticides, where we have changed the regulatory environment in the US, the UK, Europe and Japan, so that we now have a route through to market for public health insecticides, even though we were based in the UK in terms of running that program. So we've very much got a global view on what we're doing, how we're doing it, and how we partner. So this is all about partnership as well. And the more we can integrate ourselves into the networks that are already there, the partnerships that are already there, who have a voice in these areas, the better.
Yeah. Okay. Thank you. This also perfectly streamlined with your invitation to the audience to join or to get involved in ICON. Being a global player, increasingly being a global player, how do you look at collaborations, for instance, with the global AMR R&D hub in Berlin, as an example, and other global players such as GARP and then WHO?
Right. So we're a relatively new kid on the block, even though independently we've been doing a lot of this work. So literally we only started up in September of last year, and we're just getting established now in terms of who we need to set up formal collaborations with, who we need MOUs with, who we need CDAs with, NDAs, material transfer agreements in terms of some of the things that we're doing and so on. And so at the moment, I can't give you specific answers on the specific ones that you've asked me about, but those are the kind of individuals we're looking at talking to. We then collaboratively work out what is the best way to work together and get the right agreements in place to be able to do that.
Okay, that's enough. And what is also what is the funding horizon for ICON?
So we're funded for 5 years through UKRI and for 3 years through the European Regional Development Fund. That cuts off absolutely in July 2023 because, as I say, we're out of the European Union, so we can't apply for an extension in that format for that platform in that way. But I think it's been encouraging that we thought this was going to be a £120 million programme when we put the application in, and we would gear up to that over 5 years. We've been in existence for less than a year, and we've already geared up to 173 million. So clearly this is moving, and it's moving quite quickly. Yeah. It's been helped. One of the few things that has been helped by the COVID pandemic and activity that's come in from that. But I think there is potential for a lot more here if we get this right and if we make sure that it really is open and collaborative in the way that we're actually setting this up and operating it. Okay.
The longer you talk, the longer you speak, the more impressive the whole story becomes. I have one last question. It is clearly UK-based. Do you consider also setting up satellite facilities around the globe?
I haven't got that far yet, but it's possible. So as I say, literally, we're less than a year old, and so we've concentrated on getting ourselves set up, working, making sure everything is functioning, and getting the message out that we're here. If others see what we're doing and believe this is a good example, then I see no reason why it shouldn't replicate elsewhere. But clearly, we need to make sure that it's out there and delivering as we thought it was going to do.
Yeah, I'm convinced that it will happen. Thank you very much once again. If there are no further questions in the chat box or from the other organizers, then we can round off this part. So once again, thank you very much. And then we can go to the next speaker. And it is my pleasure now to introduce Jo Frost. Jo is from Innovate UK. She's responsible for the Horizon Europe UK National Contact Point for Global Health Innovation, Innovate UK. Jo, you have given your presentation also yesterday and on Monday. So those who have heard her story before can do something else now. But once again, happy to give the floor to you.
Thanks very much, Martin. So I think my presentation is still about past. So if you've heard my presentation already, you can rejoin us then for the next presentation. So thank you for joining us. My email address is on the slides, which will be sent around, available afterwards. Next slide, please. So I work at UK Research and Innovation. We invest over £7 billion per year, and UKRI consists of 9 different parts, including Innovate UK, where I work, but also the Medical Research Council. And Innovate UK drives productivity and economic growth by supporting businesses to develop new ideas. At the bottom of the slide is a link to our UK Funding Opportunities website and funding alert sign up. Next slide, please. But as Martin said, today I'd actually like to talk to you about European Research and Innovation funding, which is a programme called Horizon Europe. And this funds projects both in Europe and beyond. Next slide, please. So I'm one of the UK national contact points for Horizon Europe, and we're a free network of advisors who help support applicants. And our network is based in the UK, also around Europe and in many other countries too. Our services vary, but typically include informing and awareness raising, assisting, advising and training, and signposting. And you can contact me or other national contact points with any questions you have. There's a link to my health newsletter at the bottom of the page, and you can also link to me on LinkedIn, where I post regular updates. Next slide, please. So the EU has been funding research and innovation through its framework programme since 1984. The previous programme was called Horizon 2020, and it's just finished. And Horizon Europe is the EU's brand new research and innovation funding programme, which will run until 2027. It has a budget of at least €95.5 billion. And as you can see at the bottom of the slide, the UK has agreed to associate to Horizon Europe, which means that those based in the UK will be able to take part in projects, which is excellent news. Next slide, please. So the European Commission has published a very useful question and answer document on the UK's participation in Horizon Europe. And this confirms, as you can see on the left, that the UK entities will have the same rights to participate as EU countries. The funding rates will be the same, and the UK can lead projects. And the associated country concept isn't new. The previous programme had 16 associated countries listed on the slide, including Israel, Switzerland, Norway, and Turkey. The exact list of associated countries for Horizon Europe is to be confirmed, but other countries like Canada, Japan, and Australia have expressed interest too, so keep an eye out for that. Next slide, please. So Horizon Europe will fund, as you can see at the top, any type of organisation that includes companies and universities established in EU member states or associated countries like the UK. It will also fund organisations from many low and middle income countries around the world. The exact list is to be confirmed for Horizon Europe, but in the previous programme, the EU automatically funded for all projects 122 low and middle income countries. International European research organisations are also funded. And apart from that, if you want to work with a high income country outside Europe, like America, this is possible if it's specified in the call topic or if the participation is essential. In those cases, the EU will fund those too. As you can see in the middle of the slide, the eligibility for participation rather than funding is slightly different. Anyone can participate in the projects. However, if the Commission doesn't fund them, they would have to bring their own funding. And for most European projects, you'll need a consortium of at least 3 countries. Next slide, please. So this slide gives you an overview of the overall Horizon Europe structure. It's formed of 3 pillars, and I'll explain the opportunities in the various parts of the programme today, and we'll refer back to this slide so you can navigate around using this diagram. There's some links to some longer presentations and slide sets in the yellow box at the top right of the slide too. Next slide, please. So I'm now going to talk you through some examples of Horizon Europe funding that you can get for AMR research and innovation. All of the information on the slides is based on draft documents, so is subject to change, and we expect the final versions to be available within the next few weeks. Next slide, please. So I'm going to start by showing you some of the funding opportunities within the middle pillar in the red box. This part of Horizon Europe is split into 6 thematic areas, which are known as clusters. And for each cluster, there is every 2 years, the European Commission publishes a work programme, and the work programme has a long list of the core topics. For each core topic, there's typically 1 to 3 pages of information about exactly what the Commission expects you to do. Next slide, please. So looking at the first cluster then, which is health, there's about 50 topics in 2021 and 2022. There's some related to AMR, including vaccines, developing the next generation of vaccines, and also a topic on development, procurement, and responsible management of new antimicrobials. There's also other topics within the programme which may be of interest. So I've included a link to the draft work programme and the page numbers of the topics as well, so you can read them to find out more info. At the bottom of the slide, the EU also has some funding called partnerships. This is where the EU gets together with other funders, for example, national funders, to run joint calls. And as you can see in the yellow box for the partnerships, there's 3 steps. First of all, some preparatory work. Then secondly, the partnership of research and innovation funders is established. And then finally, as you can see in red, the partnership holds calls for proposals. Each partnership and call involves different countries, including sometimes outside the EU. So you'll need to check the partnership call text to see if you're eligible for funding. And as you can see at the bottom of the slide, there will be a partnership on One Health and AMR starting in 2024. This will follow on from the current joint programming initiative on AMR, which I'll talk about later. There'll also be a new partnership on pandemic preparedness. We don't yet know when this will start or which countries will be involved. And there are other partnerships not on the slide as well. There's another partnership called the Innovative Medicines Initiative, which will be replaced by the Innovative Health Initiative, which funds all member states and associated countries. Next slide, please. So moving on to cluster 2, this is about culture, creativity, and an inclusive society. The topics include politics and governance in a post-pandemic world, global governance in a world in transition, the role of perceptions in shaping European societies and politics. And cluster 3, as you can see in purple, is civil security and society. And this includes topics on improved understanding of risk exposure and its public awareness in areas exposed to multi-hazards. Also, enhanced assessment of disaster risks, adaptive capabilities, and scenario building based on historical data and projections. Developing a prioritisation mechanism for research programming in standardisation related to natural hazards and CBRNE sectors, which is chemical, biological, radiological, nuclear, and explosive threats. And the final topic is improved quality assurance, quality control of data, and decision-making in related to risk management of natural hazards, accidents, and CBRNE events. Next slide, please. So cluster 6 is food, bioeconomy, natural resources, agriculture, and environment. Topics include reaching the farm to fork target, research and innovation scenarios for boosting organic farming and organic aquaculture in Europe, animal welfare 2.0, vaccines and diagnostics for priority animal diseases, enhancing biosecurity and terrestrial livestock production, ecology of infectious animal diseases, biosecurity, hygiene, disease prevention, and animal welfare in aquaculture. There's also some international cooperation topics, which include a One Health approach for food, nutrition, security, and sustainable agriculture. And proposals for this must include African organisations And there's a topic on agroecological approaches for African agriculture systems. Again, proposals must involve African organisations. And finally, there's a topic on international research in infectious animal diseases. Next slide, please. So there's also a separate funding programme called the Joint Programming Initiative, AMR. If you'd like to know a bit more about this, you can also watch back Till Bachmann's presentation from Monday this week. This is a global organisation, as you can see on the map. It is an international collaboration that aligns national research agendas, and it coordinates AMR research and funding on a global scale, including on a One Health perspective. Sometimes it's possible to get funding for countries not on the map as well. So JPI AMR holds regular calls for proposals, each of which has their own funding rules. So when a call comes out, you need to check which countries and which types of organisation are funded. For more info, see the links in the grey box, including how to sign up for their newsletter. And the next call will be about AMR therapeutics. At the bottom of the slide is a link to a recent workshop in this area, which will be used to help scope that next call. Next slide, please. So the JPI AMR has a strategic research and innovation agenda. As you can see on the right, this focuses on therapeutics, diagnostics, surveillance, transmission, environment, and interventions. So you can see that full document on the JPI AMR website. Next slide, please. So I'm now going to talk about some of the bottom-up funding opportunities which are open to all research and innovation areas, including AMR. And I'll take you through all of the areas shown in red, starting first at the top left with the European Research Council. Next slide, please. So the European Research Council gives long-term funding for groundbreaking research. It funds a principal investigator known as a PI and their team, and the PI can choose to do research in any field. And the projects are selected based on the excellence of the PI and the excellence of the project. The ERC has 4 main grant schemes. Starting grants are normally for PIs 2 to 7 years after their PhD. Consolidated grants are for PIs 7 to 12 years after their PhD. And advanced grants are for active researchers with a track record of significant achievements in the last 10 years. And synergy grants fund 2 to 4 PIs to do an ambitious project they couldn't do alone. Next slide, please. So this slide is about Marie Sklodowska-Curie funding. As you can see at the top right, this funds all research and innovation areas, and any types of organisation can get funding, including industry and academia. In general, it supports research and innovation projects that also have career development, training and networking. The first scheme is doctoral networks, which provide full funding for an international consortium to train a group of PhD students, aiming to give them experience in different sectors, for example, to spend time in both academia and industry. The second one is the staff exchange scheme, which funds an international consortium to allow different staff working in the consortium to go on short secondments for up to 12 months per person. And the third is postdoctoral fellowships, where you can get funding for someone to do a 2 to 3 year fellowship. The final scheme is co-fund, which is where the European Commission provides extra funding for existing fellowship programmes. Next slide, please. So this slide summarises the European Innovation Council. As you can see on the left of the slide, the EIC covers everything right from the first idea through to the market. As shown in the diagram, there's 3 main parts of the EIC: the Pathfinder, Transition and Accelerator. For each of these, there's an open call where you can apply for any topic, and these are listed in the middle of the slide. There's also some challenge calls where the Commission specifies the call topics, and these are listed on the right hand of the slide for 2021. If you'd like more info, there's contact points in the grey box. The blue box has various useful links, and the orange box at the bottom has some information about UK eligibility. Next slide, please. So this slide is about the Eurostars programme. Eurostars is a joint programme between Eureka and the European Commission, and it's co-funded from the national budgets of participating Eureka member countries. It funds transnational market-orientated collaborative research and innovation projects, and the projects must be driven and initiated by research and development performing small and medium-sized companies. There are usually 2 calls a year, and they're open in scope for research and innovation area. We think the next call will open in July and close in October. The 45 Eureka member countries, including the UK, these are shown in the map on the top right of the slide, and 36 of these countries take part in Eurostars, including various countries outside the UK, such as Canada, South Korea, and South Africa. And projects can be bilateral or multilateral. The rules about which countries and which types of organisations are funded are explained in the call documents. Eureka also has a few other funding schemes, Global Stars, which funds projects including Eureka and non-Eureka countries, and each call specifies which countries are involved. There's also network projects and Eureka clusters, and I'll include some extra slides on these when the slides get put online. Next slide, please. The final scheme I'd like to talk about is COST. COST has open calls with regular deadlines. The next deadline is in October. You can apply for all areas of research and innovation, including AMR. COST funds interdisciplinary research and innovation networks in Europe and beyond, for example, for organising meetings, training schools, short-term missions, and other networking. So COST basically funds a global network of people and organisations who are already doing research and innovation. You can join existing COST networks. For example, there is a European network on the optimisation of veterinary antimicrobial treatment. Next slide, please. So that's the end of my presentation. I know there's been a lot of different funding opportunities to take in, but hopefully this was a useful overview of how EU funding can help you collaborate all around the world. And hopefully the slides will save you trawling through many different documents. So finally, just to say, we expect some information days on the 6 different clusters in the middle pillar to be announced soon, and also some partnering days. So please do sign up for my newsletter to stay up to date on that. Thank you.
Thank you very much, Jo, for your very clear presentation. This is the 3rd time I hear your presentation, but it never gets boring because it's all about funding, and funding is a starting point of collaboration and innovation. So once again, thank you very much. Now we come to the last speaker of today's event, and I'm most happy to introduce to you Dr. Philip Turner.
Thanks very much, Martin. Thanks for the invitation here. So I've been asked today to talk a little bit about the work we've been doing in the NIHR-funded MedTech and IVD cooperatives. I've just to sort of make a point that I'm presenting largely on behalf of Professor Gail Hayward, who leads the work within the MIC that focuses on antimicrobial prescribing. So just to sort of give a quick overview of the presentation, initially I'm just going to give a little bit of background on what the NIHR MICs are. I'm then going to talk a little bit about some of the work that we've been doing, and then I'm finally going to end with a case study of an ongoing collaboration that we have with an SME. Next slide, please. So back in 2018, 11 MICs were established by the NIHR, and this was largely because, actually going back even further, back to about 2013, the NIHR recognised that although the UK was very productive in terms of medtech and diagnostic innovation, very little was actually making it into the NHS, and there's a reason that was identified for this was that most diagnostics that were coming through to the point of certification were very under-evidenced. So the MIC program and its successor program was basically, so the MIC program is essentially a successor program to the health technology cooperatives and the diagnostic evidence cooperatives that ran prior to the 2018 point. And we essentially a bunch of centres that focus on the catalysis of evidence generation for medtech and diagnostics. So if you look at the map there, we've got four centres that focus on in vitro diagnostics. So one in Leeds, one in Newcastle, one in London, and ourselves in Oxford. And the unit in Oxford focuses on diagnostics for community healthcare. Next slide, please. So the CH MIC, so Community Healthcare MIC, is led by Professor Chris Butler, who's Professor of Primary Care in Oxford. He's got a particular interest in infection and antimicrobial resistance, and Chris chairs the Longitude Prize Judging Committee for the identification of game-changing diagnostics for antimicrobial stewardship. He's also the clinical trial lead of the Value DX project, which is an IMI-funded project, trans-European, that's looking at diagnostics for antimicrobial stewardship within respiratory infections. So essentially, the community healthcare MIC supports informed development and catalyzes evidence generation both up and downstream of certification. So we actually work on both sides, so with commercially available IVDs, but also with very early stage products that are coming out of spin-outs in universities, for example. Next slide, please. So one of the key clinical themes within the MIC focuses on the improvement of antimicrobial prescribing, and that's led by GALE. So this is the precision antimicrobial prescribing theme. Next slide, please. And improving antimicrobial stewardship in primary care is really so important as this setting handles about 90% of all NHS patient contacts. So if you look at this slide here, the infographics, you'll see that although overall consumption of antibiotics is falling in the UK, this SPAR report from Public Health England essentially pointed out last year that about 71% of all antibiotics were prescribed in primary care. And if you take into account other community settings, that's about 75% of all antibiotics. So it's responsible, community prescribing is responsible for the vast majority of antibiotics prescribed in this country. Next slide, please. And what we know about that, obviously, is that there's a direct correlation between antibiotic use and antimicrobial resistance. So AMS in this setting is absolutely vitally important. Next slide, please. So collaboration. So we've engaged in a variety of activities independently and also in collaboration or support of developers to catalyse the pipeline from concept through to evidence generation for antimicrobial resistant relevant diagnostics. So I've outlined a few key areas here, and we'll quickly walk through a few examples of pieces of work that we've carried out as a MIC. Next slide, please. So this is an example of an early modelling project that we carried out. So essentially the health economists together with clinical researchers within our group took on this project a number of years ago. And in this project, we worked on essentially as an Innovate UK funded project with an SME that was developing a point of care test to guide antibiotic prescribing in patients with COPD exacerbations. So this was it was an interesting project in that the SME initially achieved funding or acquired funding with our support from Innovate UK for a stage 1 SBRI project, and we carried that through to a second stage SBRI project, a much bigger project which is still ongoing. So within this project, we developed an early decision model to assess the potential cost effectiveness of this test in primary care setting in the UK. And we estimated that the test could potentially achieve a 30% reduction in antibiotic prescribing. Next slide, please. So this project focusing on the assessment of analytical performance of an AMR relevant diagnostic. So this was supported by European Commission grant funding and also from grant funding from Roche Diagnostics. So this project was carried out in collaboration with our colleagues from Belgium. And essentially, we, through this project, demonstrated the technical performance of this assay for the detection of flu and RSV in samples obtained from a primary care population. So this was a piece of work that was carried out using biobank samples that were obtained through a much larger project that was led by Chris Butler. Next slide, please. And importantly, to round off, I suppose, this cycle is we've carried out a number of projects looking at the clinical impact of the implementation of diagnostic tests. And this particular project, the PACE study, was an NIHR-funded study led by Chris. So a big randomized controlled trial of point-of-care test CRP-guided antibiotic prescribing for patients experiencing COPD exacerbations. So this was carried out in GP practices across Wales and across England. Next slide, please. And essentially what the trial demonstrated was that antibiotics could be safely reduced. So we saw about a 20% reduction in antibiotic usage in the CRP test-guided arm of the study. So it's a very, very nice outcome from this piece of work. So essentially taking through a diagnostic test, finding a relevant pathway into which to introduce that test, and then demonstrating that we could have a positive impact in terms of antibiotic prescribing without causing harms to patients. Next slide, please. Next slide, please. Sorry, I think we're a little bit behind with slides. Next slide, please. Thank you. So to close, I'm going to quickly run through a case study of an ongoing collaboration with an SME. Next slide, please. So this is essentially one of our favorite topics, a urinary tract infection. So I'm just going to talk a little bit about this as a clinical problem. So acute uncomplicated UTI is one of the commonest presentations that are seen in primary care. So it's normally managed. Normally, majority of patients are women, and as I say, the majority of presentations are managed in primary care. The vast majority of patients who present with this condition receive antibiotics. So our research, sort of European research, demonstrated that in culture-confirmed UTI, around 25% of infections that we saw were associated with multi-drug resistance, and a greater proportion were resistant to a single antibiotic. Next slide, please. So the current standard of care for the diagnosis of UTI is laboratory culture and an antimicrobial susceptibility test. However, this is not commonly used in the UK and also in a lot of other geographies as well, as it's far too slow to inform immediate decision making. So it's typically about a 3-day process. And one of the big issues associated with this kind of testing is that a large proportion of samples can be contaminated once they reach the laboratory, and that results in production of misleading or results which are essentially uninterpretable. So essentially, empirical prescribing is the norm, and that prescribing is typically suboptimal. Next slide, please. So Astrago Diagnostics is a company we first started talking to quite a long time ago. So it's a diagnostics company, an SME that was spun out from the University of Uppsala in Sweden from the laboratory of Johan Elf. And the company is developing an innovative diagnostic test for urinary tract infection, but also other infections. So they've been looking at, for example, using the AST element of their diagnostic for examining blood cultures from people who have been admitted to intensive care. Next slide, please. So this test incorporates both elements as discussed from the conventional culture. So we have a diagnostic element and also an antimicrobial susceptibility test component. And the test rapidly determines the rate of bacterial growth in real time within a microfluidic array in the presence and the absence of antibiotics. So essentially the chips that are produced by the company run on the platform, stream the urine sample down into the sort of microarray array bed. The technology traps bacterial cells within these traps that you can see in the sort of bottom right corner of the slide, and then growth is initiated as media is flown through the system. So essentially, what you see is that you have a sort of reference population where the sort of standard media is flowed, and you also have a side or sort of elements of the chip through which antimicrobial, so antibiotic doped media are flowed. So a direct comparison is made between the control and the treatment arms. Next slide, please. So we began discussions with Astrago back in around sort of summer 2017. And we started to give the company advisory support at that stage. So they were quite early stage at that point. Essentially, they had what was a sort of laboratory setup that they'd taken into the field to do sort of very, very early experimentation. And they were starting along that sort of process of turning that into a usable diagnostic. So within sort of the summer of 2018, we paid a site visit to Astrago in Sweden to see what they were up to and actually to look at some of the prototype tests. And then later in the summer, we started to apply for funding through the European Commission EIT Health funding stream. So we submitted an application led by us in collaboration with Astrago, but also with Region Uppsala, so the municipality near the headquarters of the diagnostic producer, and also with collaborators of ours from Public Health Wales. So that project was funded early in 2019, and we started this project in the summer of 2019, essentially initially looking at the field evaluation of the diagnostic to get usability information back from primary care clinicians and other users in primary care clinics in Sweden. We also supported the company through educational training. So they attended our workshop in the UK and received training in evaluation statistics for diagnostics and also health economics as well. So we sort of provided sort of essentially capacity building training through that. Next slide, please. So to summarize, this partnership with the MIC essentially has provided Astrago with long-term advisory support. We also pulled in this collaborative funding of nearly 600,000 euros that supported the initial study. We've continued to support them through the technical development and validation of the test. And as I mentioned, carried out some evaluation of usability in Swedish primary care clinics with a MIC qualitative support component. So sort of a lot of essentially support to develop qualitative interviews and ethnographic work to support the gathering of evidence for the usability of the test. And we've also worked up a protocol for the evaluation of the diagnostic in primary care clinics in the UK. So hopefully we'll get that going sometime in the following year or two. We supported them through educational training to build SME capacity, and we've also obviously brought into play the infrastructure that we have locally. So that includes the clinical trials unit that's co-hosted by our department in Oxford. Next slide, please. So just to say on the final point, we aim to build many more similar collaborations to this. We've got others historically. So we'd be really very happy to hear from you if you'd like to get in touch if you think that we may be able to help. Thanks very much.
Thank you, Phil, for your very clear presentation. Also introducing thereby NIHR, their work when it comes to curbing AMR. I forgot to introduce you, or actually I did not forget to do, but you already started directly, so I take the liberty to once again introduce you. You're the manager and senior researcher at the NIHR Community Healthcare MedTech and Vital Diagnostics Cooperative Infections and Acute Care Research Group at the Nuffield Department of Primary Care Health Sciences at the University of Oxford. Sorry for that, but now it's been said. Once again for your presentation. I have some questions I would like to raise to you. Maybe if there are questions amongst the delegates, then please put these in the chat and then we will forward them to Phil as well. And our first question is, it's all about what you just mentioned, antimicrobial stewardship, which is, I'm convinced, one of the key pillars or the key strategies to add to the curbing of antimicrobial resistance. And I'm convinced that there's a world to gain, not only in the high-income countries, but also in the low and middle-income countries. And when it comes to antimicrobial stewardship, what particular role do you foresee especially for GPs, for general practitioners?
Well, I mean, yeah, I think as I sort of touched on earlier, I mean, looking at the proportions of antibiotics that are prescribed in primary care, it's very, very high. Other countries are doing better than us in Europe. Interestingly, if you look at levels of resistance, one of the things that was pulled through from the study that I mentioned was that, for example, within the Netherlands, whereas in the UK and with some of the other geographies, so Spain and also so within Spain and the UK, we saw relatively high levels of resistance. Within the Netherlands, we saw lower levels of resistance, and as we've seen within that graph that I flicked up very quickly, we know that there's a correlation between prescribing and AMR. So GP is essentially the gatekeeper to antimicrobial prescribing in the vast majority, as we've seen from the SPOW report. But what GPs lack at the moment is any real diagnostic support. The vast majority, particularly in this country, of prescriptions are made empirically. So we need better evidence, we need better diagnostics, we need better evidence to support the implementation of those diagnostics so that GPs can be confident in the decisions they make. And I think the important thing to point out is I think that for GPs, the decisions are not simple decisions to make in terms of prescribing, because essentially we're thinking in the GP setting, a GP doesn't have a patient as a captive audience. They are essentially spending maybe 10, 15 minutes with a patient during which they may or may not make a prescribing decision. And essentially what they are also taking into account is not just about infection potentially, but also prognosis. And I think the prognostic factor is one of the things that weighs quite heavily on general practitioners when they're making the decision to prescribe or not.
Okay. Well, it's a clear answer. I have another question, but by the mean that these 15 minutes are not only just the Q&A part, so it's meant for questions also for the owners, not only to you, Phil, but also to the other presenters this afternoon. I have one other question before I go to the chat, because I see that there are questions now coming up. You mentioned the relevance of diagnostics, and I couldn't agree more to that. On Monday, we had presentations on the role and impact of diagnostics in curbing AMR, and presentations by Til Bachman and also by Mark Miller of bioMérieux. And what I remember from Monday is that there are many upcoming new technologies related to diagnostics of AMR, but it's not that easy. It's in fact rather challenging to get these new technologies to the market, and also to get these these novel diagnostics implemented. How do you look at that from your perspective?
Yeah, I think going back to the sort of original MO really of the NIHR for the funding of the mix, I think one of the things we're still lacking is a lot of evidence for impact. So, we did a piece of work a number of years ago where we looked at point of care testing. So not just for infection, but across all point of care tests. And we looked at the evidence domains essentially that support the different elements of a diagnostic evaluation. So we looked, for example, at analytical performance, diagnostic performance. We looked at the clinical impact, the economic impact, and the further impact of tests. And what we found was that in general, within the literature, there's a very, very strong body of evidence often for the simple diagnostic performance of a test, but very, very little evidence for the clinical impact of the test. So I think one element is trying to get more broad end-to-end evidence for some of the diagnostics that are coming through the pipeline. I think it's extremely important. I think also the funding models, because, for example, I mentioned Chris Butler's PACE study there, which showed, in a way, quite a positive outcome in terms of the reduction of antibiotic prescribing, so a safe reduction. Essentially, that intervention has not been implemented largely. So, despite that evidence being quite strong, it's not been implemented, and it's largely because there's very little funding in this country to support the implementation of point of care testing within primary care. And I think it's similar in other geographies as well. So it's not just unique to the UK. So essentially, what we found from talking to GPs who were involved in the PACE study was that although they were very, very positive about the results of that particular piece of work, they said that for them as a private practice, so essentially, I don't know if you're aware, but essentially practices, GP practice within the UK are private organisations that deliver care for the NHS. And essentially, if they do anything beyond what is supported by their local CCG in terms of testing, so the dispatch of samples to a central laboratory, they will have to carry the cost themselves. Yeah. So I think we need better cost models to support the implementation of tests where there's evidence for.
It's not only about the cost of the investments and the cost for developing novel antibiotics, but it's also for diagnostics.
Absolutely, yeah.
Phil, sorry to interrupt you, but there are more questions, and
sure.
We still have a few minutes left, so I take the liberty to go to it. There's one question I would like to mention here by Dr. Ahmed Hussein Tarak, and this is a question to Carl McLennan, if he is still there. I'm just checking. Yes, he's still there. And the question is, I'll just read the question. To increase vaccination coverage globally, the production price per vaccine is very important. However, the vaccine for pneumonia and typhoid are expensive in reference to developing countries. What steps are taken to address that?
I got a response in the chat on this in relation to typhoid vaccines. So typhoid, with its one pre-qualified producer, Bharat Biotech, currently sells at $1 a dose, which I think everyone would agree is a low price and is a price that's affordable for Gavi and UNICEF to use in rollouts. And in fact, the pneumococcal conjugate vaccines for the Gavi market are being sold at a much lower price than we'd be paying in the UK. So we're looking more like about $3 a dose, which for multivalency is very good. So what we do at the Gates Foundation as we support vaccines going forward, we do tend to do analyses early on the cost of goods of those vaccines to make sure that the actual production of them is feasible at a lower cost level. And then as these vaccines move on, often for the global health market, they're being produced by institutions which then need a manufacturer. With the manufacturers in the developing countries, so in that developing country vaccine manufacturers network, we have a number of manufacturers who can produce very large quantities of vaccine at low cost, low profit margin, which is where this can be achieved. And what we do with that as well is to supply infrastructure support for those companies such as BRAT, such as SK Bioscience, to basically have the infrastructure to produce the vaccines. So there's a lot of de-risking that goes on from the Gates Foundation and from other funders, and there's infrastructure work as well that helps. But we keep a close eye on the price all the way through, because if you have an expensive vaccine, that's not going to be taken up either with support from Gavi and UNICEF or by individual ministries in middle-income countries which are no longer able to get support from Gavi.
Okay, thanks, Cole, for this clear answer. I hope this is also an answer for the question that raised by Ahmed Hussein Tarek. Are there any more questions also from the audience? And what I said before, if you have questions, just put them in the chat and we will forward these to the presenters. And maybe also questions by the other organizers of today's event.
Yep, I have a question. Hopefully not too controversial, but there is talk, obviously, with the Corona crisis, COVID-19 crisis, about sharing IP for vaccines, etc. Is there a case to be made that, given the crisis in the AMR space, that should be considered as well?
So a lot of this, in terms of the global health vaccine, relates to the actual ability and capacity of companies to manufacturers to produce vaccines. So, in that space, it's not necessarily a case of just making IP free. It's a case of actually finding manufacturers who have the capacity and the willingness to take on a vaccine after it's been de-risked. So, I think IP is a relatively small component there, and it's making biologics is quite a complex process, particularly if you're then making it for in huge quantities. So one of the things that is important as vaccines are moving through the pipeline from developers, be they in academia or in sort of smaller institutions which can produce those vaccines, is then to identify manufacturers who are interested and then have the capacity to take these on. Interestingly, at the moment, amongst a lot of these manufacturers, their capacity is being saturated by making COVID vaccines. So, I think that that it's great that we've got COVID vaccines being produced by manufacturers all around the world. And a lot of that technology is reasonably straightforward and has been shared. For instance, the Oxford vaccine technology was shared with Serum Institute in India to produce huge amounts. So it's a case of sort of making sure that the technology is linked up with the right manufacturers who can then produce the vaccines for global health.
Thanks, Cole. It is impressive that we also focusing on the impact of antimicrobials, and with presentations from John Rex, David Powell, Summit Therapeutics, and also Joe Frost and Professor Julian Marchesi from the Imperial College in London, stressing the need and the relevance of antimicrobials when it comes to curbing AMR, but also mentioning the challenges related to research and development of novel antimicrobials, especially the lecture of John Rex, saying, it is challenging and also, so to say, not an easy way to develop novel antimicrobials, but nevertheless, we need them desperately. And then today's presentations on prevention and stewardship. Prevention and stewardship are clearly the third and the fourth pillar when it comes to curbing antimicrobial resistance. And the focus in the presentation of Carl on the vaccines, underestimated enormous potential, but we're not yet there. We're still, a lot needs to be done and has to be done. But also the impressive presentation on the ICON initiative, and I think it's clear that we all wish the ICON initiative all the very best and a lot of success in the coming years and hopefully decades to come. And then again, the clear presentation by Joe Frost on the funding. Funding remains important. And then what I just said already, the presentation by Phil on antimicrobial stewardship and in relation to AMR. We're looking back, and I'm sure I can talk about how organized. We're looking back at some very fruitful, inspiring days. And what I said at the beginning, we have been very surprised. 400 of you have been registered to this AMR innovation mission to the UK. And this is only the very beginning, because this is a virtual mission. We have 3 sessions, 3 half days, in combination with the partnering sessions. But as you all know, as you should know, or you may know, is that we also intend to organize a physical mission in the autumn of this year. And it goes without saying that you're all cordially invited also to join this physical mission. And we will come back to you afterwards, after this virtual mission, by email on much more detailed information. We are starting out the design of this physical mission, and it will probably take place in the autumn of this year, most likely in October, and take some 5 days visits to the Golden Triangle, London, Oxford, and Cambridge, to Wales, Alderley Park, Scotland. What I said, we are just currently designing the program. And the focus will be where we have a sort of a thematic approach during this virtual mission. By then we'll have a sort of a regional approach, where we focus on the strengths and the challenges offered by and the opportunities offered by the different regions I just mentioned. There will also be lectures, partnering sessions, maybe company visits of science parks, maybe also the desperately needing social program, where we can just have some fun together and drink beers and drink a glass of wine, because it's also part of innovation. And what I said, you will be automatically informed about this program, and also will receive the invitations. But we are not yet there. I mean, I think our first now challenge is to evaluate these 3 first days of the virtual mission. And I have also some practical points I would like to share with you. And the first one is that what we have said before, we will make the PowerPoint slides and also the recordings available on the website of AMR Insights, so that you can always access these and use these for your own information, share these on social media or whatever is needed. So you can just continue to benefit of the valuable insights which have been offered by all these great presenters. We will also inform you about it by email again. Then please continue to use also the Twitter handle, hashtag AMR Mission UK, because it will also give attention to this AMR innovation mission, and also will hopefully include more people when we will have the physical mission in the autumn of this year. And then we have this partnering program via the B2Match platform. We The last number I have heard is that we have over 160 partnering sessions, which is a great number of sessions, and it starts with partnering. I also have heard that there are, still many open invitations. Please respond to these invitations, either by, accepting these or by rejecting these, because this is also a manner to communicate to each other. But I obviously hope that you will accept these invitations and that you just jump into these partnering sessions, because these are the starting point. We are considering also to have a sort of evaluation of this virtual mission. Maybe we'll also invite you to answer some complete a little short questionnaires or a short survey later this year on this survey, because we will learn from it. We do need to learn from it. We are open to your esteemed and valued suggestions, remarks, comments, critics. And these are always welcome, also by email to me or to Innovate UK. So please keep it in mind. If you have an idea, if you have feedback, or also if you have an idea for the physical mission in the autumn of this year, please don't hesitate to reach out by email or give us a call or whatever. Most welcome. These are the practical points I would like to share with you. I think. Personally speaking, I have enjoyed very much these 3.5 days, and I've been enrolled also in partnering sessions myself. It has been also very, very fruitful and very informative, and this will also be followed up. I can say that I also very much appreciated the intense collaboration with my colleagues from Innovate UK and also from the NIHR and Oxford Innovation. And we had a lot of sessions together, online sessions, because of Corona. Some under pressure of time with agendas, PowerPoint slides, but it has always been great fun. And to organize this. For me, it was also a way to, being a Dutch person, also to learn how English people collaborate. And I can say that I learned a lot from the English way of collaborating. And I look forward to extending that way of collaborating also when preparing, when organizing the physical mission. What we did not have was the English beer, the English pints, but these may come in the future. We're coming to an end. We have another few minutes left, and I also would like now to hand over to Peter, who was my first contacting point of Innovate UK. And although Peter is Dutch, he's living in the UK already now for quite some years, and he tends to become more English than Dutch. Fortunately, double Dutch. So, Peter, over to you.
Yeah, thanks, Martin, for that lovely introduction there. And so maybe I've just sort of provided a bridge between the Dutch way of working and the British way of working. I won't say on which side I'm on really. I don't want to start a diplomatic incident here, but just to say a big thank you again to all the speakers and of course all the delegates as well. It's been absolutely phenomenal, not just from a number perspective, which sometimes government seems to concentrate on, but actually from a quality perspective, it's been absolutely amazing. So my job is all about international engagement and getting UK companies to go out to other markets and find partners. And as you can imagine, the last year has been somewhat of a challenge where we were used to traveling left, right and centre, and all of a sudden that stopped. It's been a challenge. But on the other hand, and again, today is a fantastic example, and also the sort of human spirit of coping with the crisis, just making the best of what we've gotten. And again, this last year has been a great example of that. If you had said a year ago that we would have worked on this, Martin, also Phil and Martin eventually, they really brought this to life and were the original instigators of this. But if you said a year ago that we would have had this 3-day conference online, pretty much without a technical glitch, there may have been one or two things, but And also the fact that it's been so hugely enjoyable as well. It's been absolutely amazing. So again, on behalf of Innovate UK and the UK as a whole, I don't want to be too ambitious, but I think that's probably worth saying. Just thank you again, everybody. This is such an important topic. Typically, Innovate UK concentrates on the economic impact of the work we do. So it's about hard pounds and pence, so to speak. So helping companies bring products to market, obviously important. It pays the tax bill, if you like. But in this particular case, it is a step beyond that. It's such an important topic for human and animal health. It's absolutely imperative that we crack this. And the last couple of days have really made me very optimistic. Again, there's so much high quality work being done, and I just hope that we've made a small contribution to accelerating all of that work. And in some ways, the really hard work starts now. So again, stepping back, this is not just about having a couple of nice presentations, fantastic as they are, but really about the connections that we hopefully have catalyzed. So anybody out there, please make the best of the opportunities that are there, and please get in touch if you need any further help. We are very, very happy to support you. As you can see, there's some fantastic work being done. Governments are fully behind this, and will be increasingly so. So again, thank you very much to everybody. Phil, I don't know if you want to say some last words, or as the AMR specialist in the VK.
I think you've said everything very well. I think this has been more of a success than I hoped. I thought it would be, but it's been really, really great. And I think that the speakers have been very, very, very good. I do look forward to continuing this as we go forward. We've got to make sure we grab this now. It's looking good, and make something of it. I would actually like to thank Martin, who's put a lot of time and effort into this, and coming up with the, talked about it originally with me, and I think we've got it, making it work, and I think it has been a great success, and we hope to continue to work with Martin very closely on this. So I would just like to reiterate everything everybody said, but please do make the most of the collaboration opportunities you've got, and because I think we've all seen it all week, we can't do this on our own. We have to work with the best people, with the best technologies, and therefore everybody's got to talk together. So I will stop there, and I'll just pass back to you, Peter.
Thanks, Phil. And that's absolutely the right tone. And again, often for me too, Martin, thank you very much for the very enjoyable and fruitful collaboration, and long may it last. And we've already been exchanging some WhatsApp messages on some other ideas that we want to talk to you about. So, okay, well, thank you very much. I'll close it off now. Have a really good part of the day wherever you are in the world, and have a good time, and hopefully see you